thank you for tuning in. It's great to be back after a couple of weeks of being gone from the Citizens Reporter, and I'm so happy that you're tuning in this evening. We have, of course, our reporter, Mark Bradley, who's here with us this evening, but we also have a very special guest who is here this evening all the way from Duluth, and I'll tell you, I really appreciate him taking the time and the effort to make it down here. He saw one of our previous programs that we had that was on YouTube, that we posted to YouTube, when we had Dr. David Feinwachs on the program in April of 2013, talking specifically about the misuse of Medicaid funds here in Minnesota by the HMOs. And Mr. Robinson has been working on this issue very in depth and diligently, and is here with different information and, well, to talk about the investigation that he undertook. And with that, I'd like to welcome you, Buddy, for coming on the program. Thank you again so much.
Thanks for having me.
Yes. Now, please introduce yourself to the viewers. Tell them a little bit about your background, who you are, and why was this a topic that was of interest to you?
Okay, well, I'm the co-coordinator of a group called Greater Minnesota Healthcare Coalition, which is made up of 4 member groups. Happen to be, the names are 7 County Senior Federation, Central Senior Federation, Itasca County Seniors, and in Duluth, Minnesota Citizens Federation Northeast. I'm also the staff director there. We used to be part of something called the Minnesota Senior Federation, and back in the 1990s, some of us had concerns about the Medicare HMOs in our state, trying to get extra profits and extra payment that really wasn't justified. And we also learned that apparently they weren't reporting all of their profits, and that some of the books had very creative bookkeeping. With other things, we learned about an audit done by the Attorney General's office, and we started digging more into this. Greater Minnesota Healthcare Coalition came to life in 2004, and with the major goal of affordable health care for everybody. And we primarily represent the economic interests of lower and middle income people. So both in terms of people that use public programs, but also taxpayers in general. And we also learned of some alternatives to how the HMOs were running the public programs. We started to wonder whether money was being used properly.
Because actually here in the state of Minnesota,
right,
Minnesota outsources some of what the state could be doing to the HMOs, correct?
Outsources most of it.
Okay.
Like over close to 90% of it. We had a role in getting a report done by the Office of Legislative Auditor in 2008, which showed that there were very excessive profits, that expense data was not being looked at, was not being verified, and there were some questions about the bookkeeping. We kept compiling more and more research, getting deeper and deeper into this. So then when the new administration, the Dayton administration, came in 2011, we showed them all of our research. We tried to convince them that they should do retroactive auditing in order to see the truth about this, and very possibly recover money that really should be due back to the state.
And that makes sense to do that retroactive audit, because then you can see what the past practices have been, and if the processes are incorrect, or somebody has been doing something in the incorrect manner, well, then you can correct it, rather than just saying, okay, we're just going to look at where we are today and do a forward thinking. Let's look back at what were those past practices and the past processes.
Yeah, and because we're talking about quite a lot of money, we compiled our research results in this report called Who Was Minding the Store, that we issued in August of 2012, and found things like over $800 million in profits off these public programs by the HMOs since the late 1990s. on over half a billion of that being excess profits compared to what they were supposed to be getting. And also all of that landing up in very high excessive financial reserves.
And typically, I mean, people think that the money that is funneled over to the HMOs is used then for the health care of the people that it's intended for. And in reality, what you're saying is that a large portion of the money actually is going into reserves somewhere else that have nothing to do with patient care, correct?
Right. And what we reasoned was that, so okay, if the profits are coming in like 3 times what they're supposed to be, like over 3% versus 1%, and the information, the expense data is not being verified, then it sounds like that information, that self-reported information, is probably inflated. And if that's done deliberately in order to get higher government money, that is fraud. But like I said, the state officials didn't seem to be real interested. But after we issued this report, the Twin Cities offices of the U.S. Department of Justice and the Health and Human Services Office of Inspector General, they were very interested deeply in what we had done.
Right, because now we're talking about, well, federal money.
Yes.
And they want to know what's happening to the federal dollars.
Right.
And now it's not a state issue anymore.
Or it's both anyway.
It's both, yes.
And you also have to look at that part of that money that is in excess is going to be then determined upon how much the executives of the corporations that are the healthcare will be receiving as their benefits, because that's part of their profit gains. And as we are well aware, the HMOs that are in Minnesota have done very well. In fact, they're some of the highest paid executives in our state are HMOs.
Yeah, a CEO salary, these are nonprofit corporations of $1 to $2 million and up, compared to those county systems that run the programs in some parts of the state getting about $100,000 salary.
Right.
And see, and a lot of times people think that when an organization is classified as a nonprofit, it means that somehow or other that they don't have profit reserves, but it's just really a type of structure used for tax purposes and how they are classified and what tax rates they pay.
Right.
And so, and there's different types of nonprofits, but that's why, again, sometimes people think, well, if it's a nonprofit, well, how could this kind of thing ever happen? Right. And yet this points exactly to the issue that you need to look at accountability no matter what the label is to an entity.
Yeah, and I was going to say, and going back to those federal investigators, so they asked for our information. November 16th of last year, we spent 4.5 hours with 10 federal agents. And 4 days later, the Office of Inspector General from Health and Human Services announced it was going to investigate to basically determine whether or not falsified information was used to set those rates, to pay the HMOs.
And you had mentioned that, a lot of this data that had been reported is self-reported.
Right.
And I think that points to another issue, is that when you have self-reporting and you don't have external reporting mechanisms to really look at the checks and balances, because when you're internal, you can always figure out a way to move those little shells around in the money game.
Right, and some of our research was very, very unique. We looked at public reports of these finances and analyzed them in ways that others hadn't. And maybe more important, we looked at documents that no one else had even been looking at in the archives of the health department.
Really?
No one else had read, even the state regulator people that were supposed to look at them.
And so what kind of documents were you looking at?
Well, the audit reports, the IRS reports, the what are called National Association of Insurance Commissioner reports. Some interesting things we found were that there's a lot of inconsistency between those reports and not even being filled out according to the correct instructions. And again, the state folks are supposed to be looking this stuff over and checking for things like that. So I do want to say, then very importantly, then in March of 2013, a new report came out commissioned by the state, by this outside expert company, the Siegel Company, to raise the question, were those rates set properly or not? Their official report basically confirmed what we had found about all the profits, the excess profits over what was intended, and they heavily stressed that the information going into this was not verified. The rate setting was very, very, very flawed, and there were repeated, excess overpayments up through into the year 2011.
Wow.
I should say, so what's happened? So the state administration has done some things. We think all of our work had a role in making that happen. In 2011, they enforced for the first time a 1% profit cap, although that got fudged a little bit. We can get into that later. For 2012, they started a bidding process for the first time for the programs in the Twin Cities metro area. They're handing over some of the Medicaid programs to hospital clinic systems, what are called accountable care organizations. They also are going to have, for the first time, a real government audit of these programs, but not starting until calendar year 2014. So we're looking forward to that at long last. The legislature put in some limits on the HMO's administrative spending for these programs, and it made some improvements in the financial reporting. And result of all this, to date, a few $100 million have been saved by getting out of these excess costs, wasted costs going forward. And even the latest budget forecast for the next biennium talks about another $55 million a year being saved. So a lot has happened. This is all good, but we don't think it's near enough because all of that huge amount from those prior years is being left untouched.
And that's right, and going backwards and trying to recapture some of that. And I know that there was this point in time where UCare said, well, okay, we see that we've got some extra this money, and maybe what we'll give it back, gift it back, or there was something about that.
Yeah, actually, I do want to get into that, but actually to kind of set the stage for that, I'd like to give a little of the backstory.
Yes.
That really helps explain all of this stuff. And the key part of this is it's focused on a desire that's been around for a long time by the HMOs and some state officials to get as much federal Medicaid money as they can into the state by any means possible. And this has been a bipartisan kind of enterprise, you might say, particularly with the previous Republican governors and DFL-controlled legislators. So it's kind of a common theme. To explain about this, I just need to first give the viewers a little quick primer on a couple of things. The difference between Medicare money and Medicaid money. So Medicare is the federal program for health care for elderly and some disabled. It is 100% of the government money is all federal. Medicaid is the companion program for low-income people of all ages, and that one, the government money is half state and half federal. So part of the justification, one other thing though, one other distinction. Two kinds of payments. One is called fee-for-service, which is where the doctors and hospitals submit their bills directly to the government for each service. The other kind is called managed care, in which instead of that, the government gives a flat amount of money per month per person to the HMO or whoever is running it. The HMO pays the bills. If there isn't enough money, then they lose money. If there's extra, they get to keep it. It's just like you or I paying a premium to an insurance company.
Right. So they have actually an incentive to run the program in such a way that they get to keep money.
Yeah. And
it sounds like they've been doing that pretty well by keeping money.
Right. See, and part of the justification for this desire is that because in Minnesota, those fee-for-service reimbursements for Medicare are among the lowest in the country. So there's sort of this kind of thing, well, we're getting shortchanged on that, So we feel we deserve to kind of compensate for that by getting as much Medicaid money as we can.
Ah.
That's been kind of the, the genesis of this.
I was just wondering, what is the impact on the patient at the end, too? Because if they're being told that they're given a fee for taking care of everything, isn't there kind of a incentive for these healthcare organizations to encourage people to stay away from the hospitals then?
Yeah, and actually they have done that. That's the one kind of achievement of the HMOs. They really goes back quite a long time ago of reducing the length of hospital stays. So that was kind of a one-time savings of money that's gone forward since. And so there's an interesting point in time here. Minnesota has some of the lowest fee-for-service Medicare payments to doctors and hospitals in the country, yet the per-person managed care Medicaid payment per person that goes to the HMOs is among the highest in the country. That doesn't seem to make sense because, the cost of medical treatments for Medicaid people shouldn't cost more than the treatments, those same treatments for Medicare people. And in fact, they don't. In fact,
because it's the same procedures, the same medical facilities.
And in fact, the reimbursements for Medicaid are lower than Medicare. So the answer to this sort of Zen riddle is that the state, when the HMOs have deliberately and very, very successfully gotten a lot more Medicaid money coming into the state than is really justified and actually that is really than is legal. So and that's why we have that dichotomy between the Medicare and Medicaid. Now, but you might say, well, but wait a minute now. If the state is getting extra Medicaid money, above and beyond what it really should get, but Medicaid is half federal and half state. So if the state is getting the feds to pay more Medicaid money, then doesn't the state have to pay extra Medicaid money too? And here's where the brilliance of the scheme comes in. The primary scheme, there are others, but the major one relates to two specific programs, which are, it's on the screen there somewhere, but
and we can put the computer screen up, the character generator, and that way we'll have it on the screen as well so people can see it.
So I'll point these out. PMAP, PMAP, is the Prepaid Medical Assistance Program. I should backtrack that all states, Medicaid is the federal name, every state makes up its own name for its Medicaid program. Here we call it medical assistance. And so we're going to call that, and this is the managed care paid to the HMOs. We'll call it PMAP for short.
Okay.
Right below that, GAMC, General Assistance Medical Care, a different program. We'll call that GAMC. And by the way, I'll be using the
and that's actually very helpful that you were able to put that on the screen there like that, so people can refer to that easily as we're talking about. That's great. Oops.
I'll get it back
as I knock it over, okay, that looks great. Because so oftentimes you hear all these acronyms, the alphabet soup as you've entitled it, and so that's great. Thank you.
And actually, while we're on that soup, HMO, in case people don't know, stands for Health Maintenance Organization, which is the correct legal name, though they like to call themselves health plans instead. And we're talking about, for the ones in this program, Medica, Blue Plus, which is part of Blue Cross Blue Shield, Health Partners, and UCare. So those are the four biggies to talk about. And while we're at the bottom, one last initial, CMS, which is the Centers for Medicare and Medicaid Services. And that's the federal outfit that dishes out the money to the state. Okay, so with that background, here's the thing. The big scheme was to try to get the PMAP program to subsidize the GAMC program. And
so it really is a shell game, isn't it?
Yeah, and this particular shell game, in order to do that, in order to make the subsidy happen, you have to shift some of the costs of GAMC onto PMAP. So what you do is you tell the feds, that PMAP actually costs more than it really does, and you tell them that GAMC costs less than it does. And so that way, some of that cost is shifted to PMAP. PMAP is straight, pure Medicaid, medical assistance, 50% federal, 50% state. GAMC is 100% state money. It covers people, the state did a great thing covering people who aren't eligible otherwise, including a lot of homeless people. But it's 100% state money. So the beauty of it is, if you shift some of the cost to PMAP, then suddenly half of that is being paid by the feds. So the state saves that same amount of money.
Right, so whatever they can shift, then they can shift it over to the other to get more funds from the federal government.
And we've really pieced together the full story. In 2000 to 2002, the state was overtly putting GAMC costs onto PMAP. But the Federal Office of Inspector General investigated and said, well, you can't do that. Medicaid money can only be used for Medicaid people. So the state, and you must stop in 2003. So the state said, okay, we'll stop. But
until we figure a new way to do it.
and it didn't take them long because because the subsidy continued, but this time in a surreptitious way. And what we believe happened is that the HMOs and DHS got together and said, well, gee, we can't overtly put this on those books anymore. So the HMOs, us HMOs, we will put the subsidy on our books internally, basically juggle the books to have the same effect. But then the state was interested, well, if you do that, we don't really want to have the documentation on our hands. So
we don't want to be caught holding that smoking gun.
Right, so I call it a version of don't ask, don't tell. And, and also, by the way, 2003, that's around the time that the current executive director of the Council of Health Plans, Julie Bruner, started with them. But in any case, what we think happened is not long thereafter, the HMOs figured out, well, gee, if the state does not want to verify our information, does not want to audit it, we could inflate our numbers a little more. And then besides helping the state get extra money from the feds that is not warranted, we'll get ourselves extra money from the state. Now remember that the original motive for the state to collude with the HMOs on this was to get extra federal money to save state money.
Right.
But we think what happened is that they basically fell into a trap and basically ended up shelling out more state money than what they were saving at the federal angle. And
now I understand, not to interrupt you, but I understand we've got a caller on the line with a question.
Okay.
So let's invite our caller to the table. Caller, thank you for calling in. Questions or comments for us this evening?
Well, it's a comment for Mr. Robinson. I would like to thank him profusely for coming down from Duluth to bring this information to us, the public, because our media in St. Paul and Minneapolis doesn't ever seem to cover these kind of things, and if they do, they make it a rosy picture for everybody. The other thing is I'm really disappointed in the state of Minnesota for not following up on the information that you brought to them, and only did it when the feds got involved. But I think the things that you have found so far is probably just the tip of the iceberg of what's really happened. And I still say I thank you very much, and the public in the state of Minnesota should thank you too. Thank you.
Well, thank you, caller, for that those comments, and he couldn't have said exactly what's in my mind as well, because we need to have folks who are watchdogs and looking out to see what's going on, and this is a classic example. Classic example.
And community public access TV has the luxury of not have to worrying about potentially losing millions of dollars of ad revenue.
That's right.
From the HMOs.
That's right. I'm not looking for any ratings here.
I was going to ask you. I know that when we've been seeing some of this mishandling of federal fundings in other areas other than HMOs, that we've also seen a, how should I say, when it's up in the Capitol, that you see some of the senators and such going to the different organizations. Have you seen that also with the people that are working the operations, that were doing the manipulations on the paperwork, going to the HMOs as a second job when they left their original jobs?
There's a
good
a very
question.
well-greased revolving door between the state agencies and the HMOs.
That's what I was wondering about.
Yeah, this Ms. Bruner I mentioned was just before that deputy commissioner of the Department of Health, and there's a lot of switching back and forth there going on. I wanted to get back to the point about this the state not wanting to do auditing. I think this history of the collusion helps kind of explain that, because even though this stuff was cooked up and done during the prior administrations, which are a different political party than the current governor, the problem is that if the state were to do this auditing and dig this out, it would probably lead to the state getting fines from the federal government for having done this stuff, even though it was in the past. Plus, the other problem is that to sort of publicly expose that kind of puts a damper on the state's reputation of good government, Minnesota Nice, and national leader in healthcare. So that's why there's some, I think, reluctance to go there. Expense is not the problem, because in state statutes, the administration has the power to audit the HMOs and charge the cost of it to those companies.
Oh, so well, and that's a good mechanism to have in the laws.
Yeah.
So like you're saying, they've got that in place that they could do it.
Yes.
It wouldn't be a cost to the taxpayer, because that they would just move that over to the HMOs.
So I got one other question to ask you. Are they trying to do, again, what a lot of other corporations, when they get caught with their pants down, are they trying to supply a certain amount of money to the government to satisfy and abstain all past histories? In other words, have they tried to negotiate their way out of these issues as they have now been found themselves dangling from?
Well, one thing related to that, because I mentioned those very huge amount of reserves from those excess profits.
Right.
So there was actually a bill in the legislature this year to, I forgot to mention that while these profits were starting to accumulate, starting in 2003 and 2004, the HMOs quietly got the legislature to remove the upper limit on how much money they could keep, their financial reserves overall. And since that time, then those financial reserves ballooned.
Just skyrocketed.
In this year, 2013, there was an attempt to put a upper limit back on and have the excess repaid. And that would have been a way for the state to recover a lot of this money. The House of Representatives passed it, but it was quietly taken out in conference committee by the lobbying of the HMOs. One thing to note, you mentioned about nonprofit status before,
Yes.
and that's been part of the justification, or you could call it delusion, I guess, because they are technically nonprofits, therefore we should assume they have a true public purpose, including one that's prescribed for them right in the state statutes. But